Well, oh, thank you, Carissa. My bad. I pushed the wrong button. Okay. Hello. Welcome, everyone. Season 5, Episode 2 of the Gateway Center of Excellence in Rural Health Virtual Lecture Series. Today's date, October 1st, 2024, and the topic for today's lecture is Rural Medical Transport, a broader national look at rural transport and EMS. My name is Jay McFarlan, and I am a member of the Volunteer Board of Directors at Gateway Center of Excellence in Rural Health. Before this lecture starts, I want to acknowledge that yesterday, September 30th, was National Day for Truth and Reconciliation, also known as Orange Shirt Day. As part of the 94 calls to action, this day asks that we all make efforts to identify and close gaps in healthcare between Indigenous communities and the general Canadian population. So through this lecture series, Gateway aims to create a platform for broader discussion and help identify and mobilize to close those gaps in healthcare across rural and remote regions. So it is my pleasure to welcome Dr. Sean Moore to help talk about the healthcare access in rural and northern regions. Dr. Sean Moore is an emergency physician working in Kenora, Ontario, where he is the Chief of Staff at the Lake of Woods District Hospital and the Northern Medical Director for the Ornge Air Medical Transport Program. He's also an Associate Medical Director with CritiCall Ontario, and his research interests include simulation-based assessment, transport medicine, and critical care analgesia. He is an assistant professor at the Northern Ontario School of Medicine and is passionate about health equity for rural and Indigenous populations. He is joined by his panelist, Anthony Sharp, base manager for Ornge and a flight paramedic by training, also in Kenora, Ontario. To thank those that are ongoing attendees of this lecture series, we offer certificates at the end of each semester to those with perfect attendance to recognize your commitment to and involvement with this educational series. Before we begin, throughout the lecture, we encourage participants, if you're watching through Zoom, to please ask questions of the panelists and the lecturer in the chat box down below, and they will be addressed during or after the presentation. And a brief disclaimer, the views expressed in this lecture may not necessarily reflect Gateway's views or opinions, but we believe in providing the platform for a wide range of perspectives and thoughtful discussion. So with that, I'll hand it over to Dr. Moore.
All right, and I'm going to attempt to share my screen here. I'm coming to you right now from a conference, an emergency medicine conference, where I am participating in the rural emergency medicine tracks, as well as the EMS and transport medicine tracks. This is situated on the traditional homelands of the Nuwu people, as well as the Southern Paiute people in Las Vegas. I'm going to share my background here. And just give me 1 second. There we go. And hopefully in a second or two, you will be able to see my slides. Yes, as was mentioned, I've been doing this for quite some time. I've been working in rural air medical transport for the better part of 25 years, and I've always been in emergency medicine, been involved with both EMS as well as transport. I have to see. Okay, there we go. I don't have any specific conflicts of interest, but I do get honoraria for speaking at the Canadian Association of Emergency Physicians, the Ontario College of Family Physicians, the Society of Rural Physicians of Canada, the International Conference in Emergency Medicine, as well as the American College of Emergency Physicians. I work at Lake of the Woods District Hospital, and I'm also a medical director at CritiCall, as well as my work through Ornge. Also of note for this, I am the chair of the Emergency Medicine Committee at the Society of Rural Physicians of Canada. I believe that all of these things actually give me a little bit more insight into this issue rather than providing a specific conflict. So over the next 40 minutes or so, I was hoping to describe some of the context of transport medicine in rural Canada and share some knowledge about this transportation. And then I'll discuss rural, remote, and Indigenous health equity concerns, specifically in the context of how we can make them better through transport medicine. This is Lake of the Woods District Hospital. For those of you in southeastern or southern Ontario, we do most things over like by the lake. So Lake of the Woods itself is a massive lake. Doesn't quite make it to a Great Lake, but it's very close. It actually has more shoreline than Lake Superior because we have 14,000 islands inside this lake. The population of the town itself, or the city itself now, is 15,000 people, and we also provide care to the 12 First Nations around this area, which increases our total population catchment to around 30,000. And we also provide services to rural and remote sections of Ontario as far north as the Arctic Ocean. So really at the far ends of Ontario. We are the only ICU that's north of Thunder Bay. We are the Schedule I mental health facility. And so because of that, we have a really, really large catchment area for which we bring people in and send back from Kenora. One of the interesting things about the way that healthcare is organized, it's provincially funded, although it's guaranteed nationally through the Healthcare Act. When we have to send a patient to get the closest pediatric trauma center, for example, if someone has a trauma, they're in a car accident and they're a pediatric patient, the closest center to us in Ontario is London. London is 1,700 kilometers from this hospital, and that puts us just a little bit further away in London than Texas. So Ontario is a vast province, and it is arranged, the healthcare is arranged provincially. Realistically, if someone is very, very ill, and if we have a pediatric trauma patient that there's time-sensitive things going on, we'll send them to Winnipeg, which is a 42-minute flight by helicopter. So the history of transport medicine and EMS in Canada is a very long one, and it's a fairly auspicious one. Land EMS started in Toronto in the 1880s. It's been around ever since, and there have been all sorts of shapes of ambulances throughout this time. But of particular interest to me and to my colleague Anthony is the air transport, which is in Canada, we were the first country that started using a dedicated air ambulance by a government agency in order to provide services to its people. This happened in Saskatchewan first in 1946. And very soon after that, there started being helicopter programs that began in Denver and in California. Now in Canada, there's a very wide range of land, rotor wing, which is what we call helicopters, and fixed wing programs across Canada, including BC EHS, STARS, which has the programs in Alberta, Saskatchewan, and Manitoba, Nova Scotia, Lifelight, Ornge, and soon Quebec will be following suit. They have thus far not gone into the helicopter and air medical field, but they are starting to, and they've just began the first 2 years of their foray into this area. So we do have a fairly unique reality in rural and remote Canada, and I'm going to speak a little bit towards our particular area of Kenora and that part of northwestern Ontario that is serviced by our hospital. The disparities in healthcare are huge. Very few things in all of medicine can you quantify by patients actually having a worse outcome in terms of longevity. But if you're a First Nations patient in this part of the world, you have about 5 years less life expectancy than folks in Southern Ontario. In fact, and also, if you just happen to live in this region and are non-Indigenous, you have about 2.5 years less life expectancy. These are very, very hard numbers, and you just don't see those kinds of things in medicine when we look at the epidemiology or the data around patients' lives. We also have like very, very significant physician and nursing staff shortages in hospitals. Everyone across the country is seeing that in Canada right now, but it's very much multiplied in rural communities. There's also a lack of equipment. In this slide, I have just a little bit of information about MRIs. So in our population of over 150,000 people in this catchment area, it covers 38% of the province. There's not a single MRI, despite us needing to send from our hospital alone 10 people a day to get an MRI. Contrast that with London, which has 11 MRIs in the similar population density of this other region. So this is something that you're going to see some changes in. You'll see it soon, hopefully, because as this data becomes available, more and more people are advocating and demanding for some sense of equality. These disparities are the most, I think, the egregious inequities that we can have. Now, one thing that's very important and quite exciting is that we can make up for some of these disparities by implementing air medical programs that I'm talking about today. So compounding some of these challenges. In rural parts and Northwestern Ontario specifically, we have 50% fewer family doctors in our communities than even the most hard-hit ones in Southern Ontario. In our situation, we have 39 physicians total that service this population, and we are the center for patients to be brought to from all of the other centers for things like psychiatry, for some of the surgical programs, for some of our diagnostic imaging, which we are a regional program for. And our emergency physicians in this area can't stop the deluge of patients coming in. We have 9 physicians. We used to have 22 before COVID. Now we have 9 physicians left doing double shifts, triple shifts, trying to keep our doors open. So these are the challenges that we have. And again, 800,000 people living in Northern Ontario. They have worse healthcare. They have poorer access to healthcare. They die earlier than people in other parts of Ontario. So one of the things that we can do is implement transport medicine. And this has been established in Ontario in 1977. The Ministry of Health and Long-Term Care started a program for Ontario Air Ambulance Service. This then evolved in 2006 to become Ornge. Again, it's an independent, not-for-profit organization that is 100% funded through the Ministry of Health. It is not cheap to provide these services. Helicopters are expensive. They're expensive to maintain with constant overhauling of the equipment to make sure that safety is there. And the same goes for fixed wing programs. This has increased in size quite a bit because even with those big costs, they are more cost efficient for providing care and for trying to get some sense of health equity for those from the rural and remote areas. I'll get into some of the specifics as we go through this. These are the bases that we currently have across Ontario. So you can see on the far left there, that's Kenora, and we're right up against the Manitoba border. Going further east, we have Sioux Lookout, Thunder Bay, Moosonee, Timmins, Sudbury, Ottawa, Toronto, London, and then a large number of land bases like Chatham, Kent, Hamilton, Mississauga, etc. And those are providing the transfers in between different centers. So if a small hospital needs to get a patient who is acutely ill and requiring specialized care to a higher level of care, such as Hamilton or any of the downtown Toronto hospitals, Ornge will bring those patients in between those two centers without them usually having to send a physician or a nurse as an escort. Again, there are some guidelines about the kinds of patients that go onto the Ornge helicopters. In general, if it's a long distance, so beyond 240 kilometers for air ambulance, they are suitable for transfer out by an airplane or a helicopter. If they need specialized equipment and skills of the paramedics, such as being put on a ventilator or a pacemaker or infusion pumps, or even very, very critical things like heart-lung bypass. So we put people on ECMO, extracorporeal oxygen, membrane oxygenation, which is a very, very acute modality that we use when the heart and lungs aren't working properly. These are the kinds of things that we will do at Ornge, and the paramedics are trained to that level, which is really, really the highest level of any paramedics in the world. There are things as well that we do, at Ornge that people might not realize. We have a dedicated mental health team. So if patients need to be brought down for assessment, pediatrics and adults, to go down to centers for mental health care, we have a dedicated team that will bring them down to Thunder Bay or Kenora. Kenora is what we call a Schedule I facility. So if patients need to get assessments and are a danger to themselves or others, we will bring them down by airplane. Now, these are tricky ones because sometimes people aren't in their, in the right way in terms of their ability to be calm and to not be agitated. And so we do take precautions to make sure that any transport is done in a very safe manner. And we have highly trained people, including a mental health nurse, paramedic, and security that is on board to make sure that this can be done safely. We are moving more and more towards care closer to home through things like telehealth, where in fact, in Northwestern Ontario, we can begin to communicate with most different centers. All hospitals have telehealth, and most nursing stations also have access to telehealth, where patients can be seen virtually by the same physicians that they would be seeing if they would go further south into Southern Ontario. Now, again, I spoke to this slightly about the levels of care, but the transport physicians, transport paramedics at Ornge are extremely highly trained. We do have some primary care medics that are being phased out of the program at Ornge. We are moving towards all critical care trained paramedics throughout the province, and advanced care paramedics, which are ACP flight, we call them, Advanced Care Paramedic Flight, are also not the same level of training as advanced care paramedics that you would see on land vehicles. These advanced care flight paramedics have a very broad scope of practice. They have extremely rigorous educational and standardized examination schedules so that they can maintain their knowledge and skills to the point where they can be with patients hours from care and doing a wide range of different skills like obstetrics, delivering babies, dealing with complications of that sort of thing, patients on ventilators that are going from smaller hospitals to a higher level of care. And really, the sickest patients of anyone in the province are what these guys, and like Anthony, who is a flight paramedic, these are the kinds of patients that they take care of. We have physicians at Ornge. We have again a wide variety of those kinds of physicians. We have emergency physicians, intensive care physicians, pediatric specialist physicians who do critical care or pediatric emergency medicine and are certified at that. We do the triaging of patients. We take the calls and we contact the various hospitals, whether it's rural, remote, or nursing stations, and we provide direction on the management of these patients until the Ornge paramedics take over their care and we transfer them down into a larger level of care hospital. It's 24/7. This is not the kind of thing that slows down in the day or the night at any point. It is a very, very busy program. We transfer somewhere around 80 patients a day, and at a busy day, it could go up to around 100. And these again are the sickest people in the province, and we are one of the busiest programs in the world, if not the busiest program in the world in Ontario. And so these are probably the sickest patients in the world at any one time. This is a major large-scale operation. The nursing station support that we give when I'm on a shift for a transport physician, I'm not just giving direction to the Kenora crew. It's across the province, which goes to the very far north, and we have video support. So when someone has a cardiac arrest, we can actually be in the room with them and try to provide the best care that we can by guiding the nurses that are on site in these communities, especially when there's no physician on site. And the very remote areas like Pikangikum, Sandy Lake, Deer Lake, Mishkaguguming. These are the kinds of centers that we will give advice and continue to do the resuscitations until we can get a crew up there. Again, sometimes weather will get into the way. It prevents us from being able to move up. We don't go through hurricanes and those kinds of things that people do down south, but we have severe weather, especially severe winter weather, which does prevent us from being able to go up and getting people. And in the meantime, we still provide that care to them. And so we provide support for the first responders in the communities, the nursing stations. And Ornge, the company, provides some of the gear that patients need for proper diagnoses, like the iStat, which is a laboratory analyzer that gives us answers in a point of care fashion. So when someone gets their blood tested, they put it into a tiny machine, we get some answers, and we can figure out a little bit more about how sick they actually are, and react to those answers before we even get there. There's another organization in Ontario called CritiCall, where again, they're kind of like the switchboard for, if you're a switchboard at a hospital, if you need to find Dr. Moore, someone will phone through the switchboard and they'll get me on the line. It's the same thing for CritiCall, except we're going between institutions. So if I've got a patient that is in Kenora and they need a vascular surgeon, so they may have an aneurysm that is about to blow in their abdomen, they will get me the closest vascular surgeon in Ontario, or in our case in Manitoba if we request so. And then if the patient is at risk of losing life or limb, they'll facilitate the call by organizing with the Ornge Air Ambulance programs. And so we work very, very closely together through these two programs. And the life or limb program. So again, if someone is at risk of losing life or limb, and it's declared by the physician in a small hospital, let's just say for the sake of argument that it's in Atikokan, again, Northwestern Ontario, very small hospital with family physician coverage, rural generalist coverage. And they realize that this patient needs to get transported as soon as possible, or else they're quite likely to die. We will get a regional critical care response team with an intensive care physician at Thunder Bay involved on the phone, and the physician on Ornge on the transport end of things. And we come to common agreement about what is going to be necessary to move these patients to a higher level of care, and how to do so safely and resuscitate whenever possible before they even leave the doors of the smaller hospitals. This really does bring, and when Ornge comes, we call that, we're bringing patients to the talent. So we might have a vascular surgeon that has the ability to treat something, but we also bring talent to the patient. So we bring these paramedics who are exceptionally highly trained, and by and large, a good portion of the patients that they're transporting get stabilized before they even leave these small rural and remote places. We also do responses directly for things like trauma. So if someone has a car accident, a severe car accident along Highway 1 and in the Trans-Canada Highway, goes through some of the most remote places, including Wawa, where you're hours and hours from a trauma center. Ornge can arrive, do a number of different critical interventions, like putting on a pelvic binder if they have a pelvic fracture, like putting in a needle into the chest to relieve pressure. When you have something called a pneumothorax, and it's like your lung can deflate and you can be under tension in there, which stops your blood from pumping effectively by your heart. They can insert a needle and allow for things to return towards normal. They also, in Southern Ontario, in a number of the different communities, now carry blood on board so that they can actually deliver blood when necessary before they even make it to a hospital. These are, again, are programs that have evolved. We haven't gotten them in the north yet, but we do have them in rural Southern Ontario at this time. Another thing that CritiCall does is arrange when we don't have any room or the right skills. So let's say somebody is in Windsor, Ontario, and they have a scuba injury because they're near the Great Lakes as well. And sometimes scuba divers may get complications of scuba, and diving that require going to a hyperbaric chamber. Well, there's one right across the border in Detroit, and so CritiCall arranges for those transfers across the U.S.-Canada border. And during the day, that's the Ministry of Health that gives that permission. And at the nighttime, it's guys like me who work in CritiCall and make those arrangements. And Ornge does do those flights, so we will fly patients across the border to the United States when necessary. It used to be a lot more common because we didn't have the infrastructure in Canada to be able to provide the care that we needed to for some of the most sick patients. But now it's very rare that we actually have to bring them across to the States. I also want to point out that transport isn't always by ambulance or air ambulance. These are photographs from various things that I've done throughout my career, including going and landing in rural and remote places. The top left picture of the back of the pickup truck is somebody inside a sleeping bag because they were hypothermic, and the only way to bring them out to the helicopter was by putting them back of a pickup truck. This is the state of affairs in some communities. They don't have ambulances. And so, they're in the back of a pickup truck. The top is a hyperbaric chamber for scuba diving that I was involved in a film crew, and off the north, like in the very, very far north, by something called Bylot Island. It's a place that is very close to Resolute in the North Pole, and we are providing we're bringing patients to in a search and rescue kind of fashion to healthcare in that way. So again, I'm not just focusing on Ontario in this talk. I'm talking a little bit about some of the national side of things, and there is a distinct difference between search and rescue operations and the kinds of programs like Ornge, which do we do scene calls. We can arrive on a scene for a trauma, or we can do interfacility calls, which is between one center and another center. The current state of affairs, this is an article that came out in September 2020. Sorry, I didn't change the 2023 in here. I'm a little behind the times. So this describes in great detail what it is like in the transport world across Canada. And we talked a lot about the kinds of things that were and weren't available in rural and remote Canada. And then one of the sections in here, we talked about the myths of transport. And I talked about some of the basic premise of healthcare being transferable between provinces, and also that people expect that the care that they get in rural and rural areas should be equivalent to the same care in downtown Toronto, that people are guaranteed the highest level of healthcare possible. And the reality is that we can get there through transport medicine when we're bringing people where they're needed. But with rural and remote Ontario, there's no way we can afford to put a cardiac surgery program up in the far north where they wouldn't have the skills, the maintenance of skills, because they wouldn't be doing enough cases in time. So this sort of hub and spoke type of a program where you have major centers that are centers of referral, and then they will deliver care to a lot of the smaller areas, and we bring them in through transport medicine. That's how we try to achieve more of the equality in these types of things. Virtual care has really come a long way as well. And just like us presenting virtually, I'm presenting from the United States right now, and the others in the room are from all across the country. And across the world, we can deliver a lot of the real-time care through multiple jurisdictions and get specialist help with the care before the patients ever leave the room. So as long as we have the right medications and someone on the ground who can provide the types of interventions that are necessary, we can use a lot of the brainpower to deliver that care at the site where the patient is. Now, one of the most interesting things about transport medicine is that it is the common ground between the urban and the rural. We bring, again, skilled personnel to rural locations and transport patients to specialized care. One of the hardest things we have as far as barriers go in getting people to higher level of care is that the high level care places like Sunnybrook or London Health Science Centre, et cetera, they're always full. They're always jam-packed full. And if they are, and you're in a rural place, well, we still need to get our patients into care. And so when we don't have enough beds, we will continue, again, bringing patients, even though there's nowhere really to put them, which is why we end up with hallway medicine. Well, we have patients that will be flown and not, if there's no ICU beds available, they'll end up in an emergency department where it's not quite as well staffed, for example, for as a high level ICU. But it is sort of the best that we can do. And when I speak to folks, when I'm telling them this patient needs to get to a tertiary care center from my smaller center, my expectation is that they will understand that the patient's life is at stake, and I would not be asking unless it was actually important for them to go there. And one of the things that I'll end up saying, and when people say, "Well, I don't think this patient's sick enough," is I'll answer, "Well, either I know what I'm talking about, and this patient really needs to be in tertiary care, or I don't know what I'm talking about, and the patient really needs to be in tertiary care." And so it's usually a little bit of humor, but also the reality of the situation, explaining to people really does help and goes a long way in collegially and collaboratively working in the best interest of our patients. A couple of years ago, I was participating in and helped in a very large call to action for rural and remote communities in Canada. We put out this publication on our approach to patient transfers for those living in rural and remote areas of Canada, and really described the most important things that we have to do to advocate. And this is where anyone that happens to be on this call or watches this has a part to play, because we need advocacy and we need action from folks that are outside of the healthcare system and demand that we try to find ways to achieve what we're talking about in this paper. What do we talk about? It's basically a vision that those who live in rural and remote communities in Canada should expect a high standard of care when patient transfers are required. Very basic, and I believe that wholeheartedly. And we looked at the principles of patient-centered care, that care should be safe, it should be equitable, it should be accessible, it should be appropriate and integrated. And system-based planning is necessary to get those kinds of things. Where we don't have equitable care, I presented that in the first slides. Patients die 5 years sooner in northwestern Ontario than they do in major centers like Toronto or London, et cetera. It should be accessible. Well, we don't have access to things like MRIs without sending patients for up to 2 days away from where we are to get those kinds of tests, et cetera. And again, integrated, we don't really have certain aspects of transport worked out where we have, no refusal policies and that sort of thing, which is where, and I'm coming to it right here. So leaders and people, public citizens alike, we need to try to get formal patient transfer agreements that make sense. We've been working on that in Ontario for the last 2 decades or 3 decades. But it hasn't really come to fruition where patients, where I can pick up the phone and say, "I need to send you this patient," and they just say, "Okay, when are they arriving?" That's what we need. We can't continue on with saying, "Well, maybe they're not sick enough. We don't have any room. There's not this, there's not that." We have to implement no refusal policies. This is in effect in several provinces across Canada, and these have been extraordinarily successful. BC, Alberta, Northwest Territories, Nunavut, they all have no refusal policies in place that have really, really worked for the patient's best interests. We need to make that a nationally accepted practice, that we have no refusal policies in every province and territory in Canada. We also have to make supportive intra and interjurisdictional infrastructures. When COVID came along, it became apparent that we didn't have enough beds in Ontario, and then so we had to send some patients to Manitoba. Manitoba ran out of beds after that, and they needed to send patients into Ontario. And that was a really eye-opening moment when we realized that we were sort of practicing without a license for patients that were coming to Ontario. And so we approached the colleges of physicians and surgeons and worked out in very, very rapid fashion the infrastructures in place and the allowance for all of us to work nationally through what we call mission continuity. In order to do that, we had to get the College of Physicians and Surgeons of Ontario, the College of Physicians and Surgeons of Manitoba to meet, the Ministries of Health on both sides to meet, and really work out those kinks. We were able to accomplish that in weeks. At this point, what we're trying to do is get national licensure for physicians and paramedics, hopefully, in the next coming years, so that patients can move across boundaries. They're not borders. We don't have borders in Canada between provinces, but we want people to be able to move fluidly throughout the system wherever necessary and move to a place where they want to work and still have the qualifications and not have to go through a million hurdles and hoops in order to get that done. We also want, again, for these calls to action, we want to leverage virtual care technologies for care closer to home. We have a really good program in Ontario, but that doesn't exist in some provinces, and it's much less robust in places like Quebec, and in some parts of the Western provinces as well. It is not as well run, and there are things missing. We also don't collect the right kind of data at this point. We collect all of the data for every transport that's done, and Ornge has done some amazing research. But CIHI, the National Data Collection Agency for Healthcare, doesn't collect information and some data of things that we really, really want to have happen. So anytime a patient is transferred, we get the information recorded for those types of things so that we can do some planning, et cetera. But if a patient dies before going to somewhere larger and they're waiting for transport, we don't have anywhere that information stays. So we have no idea how much, how many bad outcomes actually occur. So we need to be able to do end-to-end planning. So what about physicians and transport? Because there are countries where the physicians are on board, and Ornge right now has a program where a certain number of physicians are being trained to work alongside paramedics. We have nurses that work alongside paramedics in certain programs. But I'm just going to say briefly my view on this. This is not the view of Ornge or Gateway or anyone in particular, but physicians in general are most helpful doing the things that they know what to do. So providing diagnosis, giving orders for what needs to happen in terms of the best practices for that patient. Paramedics are expert in packaging patients, running the medications in through infusions. They are expert in this, and this is something that they are also good at detecting deterioration and doing the types of skills for life-saving interventions. So that's the best bang for our buck, is to have highly trained critical care paramedics throughout the province. And it's more important that they're in the rural areas than in the urban areas. If you have a transport of 10 minutes from somewhere downtown to a tertiary care center, there's not going to be a whole lot of time for deterioration or for interventions, for that matter, to occur. But if you're on a 2 to 3 hour transport, or even a 5 to 6 hour transport with a patient, there is a lot of things that the patients can benefit from during that time. So it's most important that we put these critical care resources in the far-flung areas of Canada. Just going to check in on time. I think you're getting towards the end here. So this is all of the gear and folks that would be involved in a typical helicopter or airplane trip. So we have a couple of pilots, we have a couple of paramedics, and then they have a common kit that they would have, whether they're in an airplane, a helicopter, or an ambulance. These medics know inside and out where every piece of equipment is. They check them on a regular basis. They make sure that they have the right medications, that they have the right tools, the right equipment, and that they are fully charged and ready to go. This is every shift kind of thing. So every 12 hours when they change over, they're checking all of their gear and knowing where everything is. The hard work for transport happens before people go out the door. So my job as a doctor on Ornge is to phone up the place, the hospital or the nursing station where the patient is, and make sure that they get they get an IV. If they can't get an IV, we put in an IO, an intraosseous line, where we drill into the bone, and we secure a way to deliver medications that way. That they have all of the lines, so that they have ways of measuring blood pressure that work when you're in a noisy environment like a helicopter, or a jostly environment like an ambulance, where it's very difficult to do things like measure a blood pressure. So we do this in a different fashion when patients are very, very ill, and we need to know moment to moment where their blood pressures are. We also make sure that they get appropriate pain medication and sedation, et cetera, et cetera, et cetera. So these are things that happen before they go out the door. And then when the paramedics arrive, sometimes they're still working on those things. And so the paramedics do all of the preparation to make sure that the patients could be provided care en route safely. Because there is nothing worse than delivering a baby in a helicopter where you don't have the equipment or space, et cetera, or running a cardiac arrest in a helicopter, when things can be worked out ahead of time to avoid those situations. The other thing about nurses or physicians or others that are taking, if they have to go along with patients, that sometimes takes them as the only resource out of various communities. When I was working up in Tuktoyaktuk and Inuvik in the far north, if I had to go along with a patient who was dying, I would do so. But that meant that there were no other practitioners in those areas. So it's a really, really big impact and decision to be made when we have to take people out of various communities. This is why paramedic programs are so vitally important, and air medical programs really, really do allow for us to have a sense of health equity. In general, air versus ground, there are differences in the scopes and the sets of and the skill sets for paramedics on land ambulances, as I've alluded to before. The true time requirements, if there's going to be a 2-hour transport, there's no question it's faster by helicopter. A helicopter between Kenora and Winnipeg, it's a 42-minute flight. If it's the same thing on land, it's a 2-hour drive. So if that hour and 20 minutes is going to make a big difference, well, then we're going to take the option of a helicopter. If they're going by fixed wing or an airplane, well, then you have to take the patient from a hospital and go to an airport, transfer the stretcher over, put the stretcher into the airplane, fly to another airport, take them off that stretcher, put them into a stretcher for a land ambulance, and drive that land ambulance into a hospital. Well, that generally takes more than 2 hours. So it's even faster by land sometimes. So we take into consideration all these kinds of things when we're making a decision about what kind of resources are going to be faster. And so there is an operational side of Ornge that does all of that. They give us the information. If we go by helicopter, the patient would arrive in the tertiary care center at 9:43. If we take them by land, they're going to arrive at 11:20. If they go by a fixed wing, well, it's going to be 12:10. And so we have to make a decision then. Is that time going to make a difference, or would it be better to have the helicopter available in case there's a car accident? There's a lot of that stuff that goes up in play behind the scenes. And we also, and I'm going back to the obstetrical care thing, this is a map of where every transport occurred over the period of a year from certain communities, and then delivery occurred in a larger center within Canada. And the width of the lines and the width of the circles designate the actual numbers of cases that would go and get delivered in these various places. It's pretty hard to see. It doesn't televise well, but that is a map of all of Canada and all of the obstetrical cases that occurred. So we have a significant number of patients that are transferred, but we bypass centers in some cases that are capable of providing the right kind of care for those patients. And that's something that on a national level and on a level where people are making decisions about how we do these kinds of things, they have to get this kind of information and data. There's big impacts, by the way, for providing advanced and critical care on helicopters and going out to see patients. If we look at some of the information from papers that were done in the United States, if we really stick to the core principles of providing patients with high levels of care with brain injuries, we can virtually equal the same effect of patients being having those kinds of injuries within a city and with no transport time. It is really the order, the standardization of the management, and then bringing patients to the right centers. If we look at, again, rural areas using standardized management protocols, they have the same kind of adjusted in-hospital mortality as those that end up in dedicated units. So it's what we do, not exactly where we do it. And that's something that we are bringing to the table with the helicopter programs. Some of the things that we see are done in rural areas is sometimes patients are under resuscitated. Sometimes we initiate transfer too late to places that may not be accepting them. So it's not, I'm not putting blame on any of our small centers like my own. What I'm saying is that we're sometimes at the mercy of weather, staffing, our relationships with the tertiary care or the high level of care centers, and we all have to support each other in these ways. So in summary, I just wanted to present a bit about the landscape of transport. It's changed dramatically over the last 20 years and the last 100 years for sure. It's a huge factor in healthcare equity for rural and remote areas. We have to bring the talent and skills to the outlying areas so people can expect the same kind of care and the same kind of outcomes. When they see an H in the back, in the distance and they're driving towards a hospital, whether you're in Temiskaming or if you're downtown Toronto, I think that we need to expect that we're going to have equitable access to care. And finally, again, if people want to get into this kind of business, talk to your members of provincial parliament and make sure that they work towards getting care for your rural areas. So that is all I have for my my presentation, but there's time now to answer any questions, and you can pepper Anthony there as a flight paramedic with any of those questions as well.
That's great. Thank you, Dr. Moore. And Anthony, I'll go straight to you first. Do you have anything that you want to add to what Sean was just talking about, or maybe address the question you answered in the chat?
Sure. Two things. One thing, when Dr. Moore is talking about what air ambulance brings to a scene call, it's a very different approach than the land service. So the land ambulance gets the scene, gets the person in a stable-ish condition, and gets them to the hospital quickly. What flight paramedics bring, particularly at Ornge, is they bring the first 30 minutes of what the emergency room can do, with the exception of a CT or an X-ray or an MRI. So they have the medications and the equipment to provide that care right at the scene, which basically brings you 30 minutes closer to the hospital particularly in a trauma. As far as the question in the chat was about weather, and as you get into the least populated areas and the more northern areas, the reporting stations across Canada get much less frequent, and therefore their reliability gets much worse. And so our pilots, certainly at Ornge, and I'm fairly confident this can be nationally, use their experience because none of them are coming straight out of flight school to be pilots in EMS. So they're using their vast experience along with the live information they have available to them from the reporting stations in order to make a decision. And then once they decide to go, the team heads towards that patient, looking for the safest way to do it. If it's not safe to land, then they abort the mission and return and wait for the next opportunity. Never forgetting that there is a patient there. Our communication centers make sure that we're constantly checking in, giving doctors like Dr. Moore the opportunity to touch back with those communities and provide additional advice and orders in order to care for those patients until we can arrive.
Great. Thank you for that answer. David also had a follow-up question there. Is how often is patient transfer delayed by bad weather, or do you collect any stats on that?
I don't believe we have stats on that, but I can say, generally speaking, that delays for weather happen mostly sort of that November to January time period, where right across the country you have that we're not in fall and we're not in winter, so we have low cloud, lots of freezing at various levels. So for helicopters, that's a no-go situation where we can't fly through clouds in a freezing condition. So from +5 to -5, basically we turn into an big ice cube essentially and would fall out of the sky. Planes have more ability to do that. So that November to January period, depending where you are in Canada and BC, it's probably a bit longer, and Newfoundland also probably a bit longer just because of your climate. But in the center part of Canada, it's sort of November to January where we're in that in-between period where it's not really cold, but it's not warm enough for us to fly through a cloud. So that would be where it would typically happen, but I can't say that we have a number. I'm sure there is a statistician somewhere at Ornge who can give you the exact number. I can't, but it's not something we publish, certainly. But yeah.
Yeah, and it's something it's really hard to do. And again, there are places like Moosonee to Moose Factory where during freeze up and thaw, it is people, in the summertime go across by boat. We actually bring patients across by boat, and in the wintertime, people can drive on ice roads, etc. And during those other times where it's, again, unfortunately, those are some of the times where we do encounter weather the most. It can be really difficult to bring patients even short distances across. But one of the things that Ornge has done in recognizing this is that every helicopter base, I think it's, Anthony will correct me if I'm wrong, but every helicopter base also has land vehicles. And so that if there is bad weather, well, they can still go and do the drive, even if they can't fly out. And that has really had a big impact as well, because having, land ambulances and our paramedics going on the land ambulances, well, they're all so busy. They're all, there to get 911 calls and take patients. And so we get bumped further and further down the line, because sometimes we have to make triage decisions between someone who's got no care, they're in a car accident or they're at their home and they're having a heart attack, versus someone who is in a hospital but not getting the kind of care that they actually need, because they might need surgery that isn't available in a small rural place. And those kinds of decisions are really, really difficult to make, because it's basically comparing apples and oranges and saying, my orange is dying and my apple is dying, but at least, this one has a doctor at their side. But that doesn't always help. So just getting land ambulances wherever there's a helicopter has dramatically changed the amount of patients that we can transfer.
And in fact, to add to what Sean said, it's actually at every one of our bases. So every airplane and helicopter has its own truck. So for weather or mechanical purposes, if we can't respond in the helicopter, the paramedics are then assigned to the truck. For a place like Lake of the Woods, that means additional 100 patients a year were able to be moved by our staff. Rather than having to sit and wait for the next aircraft or for the weather to clear, an additional 100 patients over the course of a year can be moved by that truck.
Wow, that's great information. I think that really answers one of the questions that Penny had in the chat about triage and how those difficult decisions are made. So having those land transport options, that is a huge benefit there. I actually had a question about the staffing for this very fast-paced, physical and high-stress environment. Do you see a lot of turnover with advanced care paramedics with the flight training? Is there just as much need in this particular facet of healthcare as we see for nurses, the PSWs, and physicians?
So what's interesting is there is the need, and because we are growing, we're adding always adding to the system because of the demand. So there is the need, but the turnover is not nearly as high as it is in other areas. And so once you get into the air ambulance, people seem to stay, which is great. But they do like to migrate to the south, which is also a problem, because it means that our bases in the north are always challenged at keeping staff in these remote areas. But certainly we have done everything to across Canada, the recruiting of paramedics and training of paramedics up to advanced and critical care levels is in full throes. We are now bringing paramedics from Australia, South Africa, and England to join us because we just can't get enough in paramedics at that level of care who are already trained to supplement what we already have in our communities. But we are working towards it. The turnover, though, is not nearly as high as what you would see with a nurse or maybe even some of the land paramedic services. Once people seem to get into the program, they seem to stay because it's a different pace. The medicine is different, and your role is different in the system. And so you're not doing just 911 calls all day. You're not doing just interfacility calls all day. It's a bit of both, and you get to see parts of the world you would never get to see in any other situation. And for many of us, I think the logistics of being sent to Fort Severn, a community the farthest point in Northern Ontario, that's hours away from a hospital, and it's you, your partner, your pilots, and a doctor on the other end of the phone who are going to bring a patient who is perhaps as critically ill as the patient in downtown Toronto to care. And so that exhilaration is a game changer.
I'll add just a little bit about the training in that. If you take someone from the north, you train them in the north, and then give them a job in the north, they tend to stay. And so what we have to do at this point, we're nowhere near having the facilities to be able to do that training everywhere. But Ornge does a really good job of getting getting paramedics trained from the north who are from the north, and hiring people so that they can live out their careers there. A lot of us would love to, be able to spend all of our careers in the north, but where there's times where for our training we are forced to go to other parts of the world. That's the key to this. And we're also importing a lot of people. If you're on Ornge, there's a good chance you're going to hear some Aussie or some British accents because we import these people. We realize how hard it is to find critically or advanced care paramedics and then train them up to the level that we are doing in Ornge. And then, as Anthony was saying, people don't quit that job. It's a really high stress job where you'd expect the turnover, but there isn't, because you're doing such amazing medicine. That's what keeps us. I don't know of a single physician also at Ornge that's ever quit. I mean, there's a couple who've retired. But no one wants to move away from a place where you're doing such interesting work, and it's such gratifying work, because this is the real deal. It's sometimes in the emergency departments when you're treating patients, or even on the land vehicles, you're moving people who really aren't sick. They may have a perceived sickness, like they might think that they're unwell, but there are people who call for an ambulance every day of their lives. And there are people like in an emergency department who come to the emergency several times, even every day. And sort of the stuff that happens at Ornge, these are really sick people. These are patients where we have to think and put our heads together and work as a team in order to deliver the care that's necessary to save their lives. So it's hard to beat as a job. This is the best job I've ever had and ever will have.
Great. That's all just amazing stuff. And then there's some questions that we didn't get to in the chat, but I want to thank everyone for their time and realize we're coming up on our hour of power here. So as we conclude this lecture, we hope that this has proved to be educational, insightful for everyone all about rural transport medicine and all the people behind it. Huge thank you to Dr. Sean Moore, Anthony Sharp for educating us. We'd also like to thank our sponsors, wonderful sponsors, for their continued support. Without them, this lecture series, the lecture series would not be possible. So McGee Motors in Goderich, Huron Tel, the Jaggers Pharmacy in Goderich, CIBC Wealth Management, Libero Credit Union, Tucker Smith Communications. Thank you. Gateway is a not-for-profit organization with charitable status, and we greatly appreciate and welcome any support we receive. Gateway is excited to announce a bonus lecture in conjunction with the Huron Immigration Partnership on Thursday, October 17th at noon with co-presenters Dr. Salima Alana and Dr. Jennifer Dean. They will be talking about immigrant healthcare. Thank you again to our panelists, our sponsors, and especially the attendees for tuning in, and we'll see you next time.
Thank you.